Okay, so let's begin. Welcome to this virtual town hall on kidney care during COVID-19. I'm Barbara Fain, the Executive Director of the Betsy Lehman Center for Patient Safety, which is a state agency in Massachusetts that works to improve the safety of healthcare in all settings throughout the state. Tonight's discussion is a joint effort of the Betsy Lehman Center and the iPro ESRD networks, which span much of the country. Improving the quality and safety of care for kidney patients is a key element of their mission. This town hall was also developed with help from the Massachusetts General Hospital Transplant Center. You'll be hearing from doctors and nurses at the center today who will talk about the ways in which kidney transplants have been impacted by COVID-19. I'd especially like to thank Jody Jones-Turner at Mass General for all of her behind-the-scenes help to make tonight's event informative for all of us. So before we dive into the content, I just wanted to mention a few housekeeping items. Tonight, we're going to have 4 different presenters, and after that, we're going to have time to answer any follow-up questions that you may have. So as you're listening to these presentations, if you have a question that you'd like to ask later on, you can use the chat feature on Zoom to type it in at any time. You don't have to wait till the end of the presentations. As you can see on your screen, there's a chat icon. You can click that opens up a box, and then you just type and send your message in that box. And I know many of you have become, during this pandemic, Zoom aficionados, but if you're new to it, it is pretty straightforward once you get used to it. Please let us know if your question is for a specific presenter, and we're going to address as many questions as we can at the end during the Q&A. When we get there, you're also going to have the option to raise your hand, and we'll explain how to do that later if you would prefer to ask your question that way. I also want to mention that we do record these town halls, and the chats are retained as well. And this is so that we can post them later on to share with people who aren't able to tune in right now during the live presentation. Your video will not be displayed on the recording, but spoken comments will be. And if you have any concerns about the recording, you can send a chat message to the Betsy Lehman Center. Our agenda for today will be listed on the right-hand side of each of your screens, so you'll always be able to see where we are in the program. Before we dive in and I introduce our first presenter, I'd like to ask you to participate in a very brief poll so we can learn a little bit about who you are. You're going to see questions pop up on your screen. And you can click next to the answer or answers you want to choose and then submit your responses. So I'll give you a minute to do that. Okay, so why don't we end, a few more responses coming in. Why don't we end the polling? We can just show you the results. So, as you can see, actually the largest group of you are actually on a transplant waiting list. So, so that's great. And I think the information you're going to hear this evening is going to be really important. And then let's see. Many of you, some of you are on dialysis and some of you are not. And then to the question about whether your dialysis facility provides you with education and support on transplant referral and workup, most of you for whom this question is relevant say yes, so that's good news. So great. As a final just housekeeping item before our first speaker, I wanted to let you know that all of the resources that we're going to be sharing today will be posted after this town hall on the Betsy Lehman Center website, and Sam is currently typing that URL into the chat box so you can copy it and access it later. So without further ado, I am now really pleased to introduce our first speaker, Dr. Leonardo Riella, who's going to discuss why kidney patients consider transplant. Dr. Riella is the medical director for the Mass General Kidney Transplant Program and has a research laboratory focused on understanding immune regulation and the development of novel therapies to promote organ tolerance. So over to you, Dr. Riella.
Thank you so much. It is my pleasure to be joining this webinar. We'd like to thank Betsy Lehman Center for the opportunity, as well as the iPro for coordinating this. And I also want to thank all the audience, patients, family members, providers that are participating on this. And I'll share some of my passion in transplantation and share some of the tips that we may have for patients who are waiting for their transplant. And I think it will be useful as we walk along this path. Next slide, please. So what we're going to be trying to answer in the next 10 minutes are basically three main points. Number one, why should kidney patients consider transplantation in the first place? The importance of timing of referral, and I know a lot of you, it seems, are already on the wait list, and talk a little bit about how the wait list works and how can you actually get a deceased donor transplant a little bit earlier than other patients. And those are the three main focus. Next slide. So I think that the first important question that I think many of you have realized is that a kidney disease, unfortunately, has not a lot of symptoms until it's very far along. And we use a blood test, the creatinine, which is something that's filtered by the kidney to tell us how much the kidneys are actually working. And we use a formula that's called GFR to estimate the kidney filtration. And we start with a GFR of about 100. And as we lose kidney function, this GFR kind of drops. And then as it gets below 15, this is when you're, I'm sorry. No. So sorry. When kidneys are failing is when your GFR is below 15. And this is when we start considering and start thinking about transplant. Next point. And then one of the most important aspects about planning the treatment of kidney disease is actually to start planning things ahead when your GFR is below 25 mLs per minute. And we'll talk a little bit more about that. Next slide. So when we think about your kidneys failing, there are about three potential treatment options. Kidney transplantation is number one. The second one, next, is dialysis. And many of you have heard are on either hemo or peritoneal dialysis. And third, there's a small fraction of patients that may consider what we say conservative treatment. So these are patients that have a limited life expectancy and therefore may have a much shorter expectancy in life and may desire not to undergo dialysis or transplantation. Next. The really crucial point about all this, independent of what treatment option you may consider, you have to start thinking this over 1 year before you get to the point of actually needing a treatment because of kidney failure. Next slide. So number one, why do we favor transplantation? And one of the main reasons is that even dialysis is an efficient way of filtering the blood. Unfortunately, the risk of dying on dialysis is almost 6-fold higher than in transplantation. Let me translate that into a little different way. Next slide. Say if you're a 60-year-old male and you started on dialysis about 6 months ago. So if we think about what is your estimated survival in the next 3 years, out of 100, about 30 patients, unfortunately, may die on dialysis in the next 3 years, compared to only about 5 out of 100 if you're a transplant patient. Next slide. And if you put this in perspective, dialysis, even though it's a treatment that filters the blood, it doesn't filter as effectively. And the risk of dying may be even higher than certain cancers. Next slide. So what is kidney transplantation? So it's an operation that places a healthy kidney from another person into your body. And usually you want to do in a center that has a lot of experience, that has a high volume. The surgeons have to be technically very gifted in order to connect the kidney and make sure there's no complications. The higher the volume of the center, the higher the experience and the lower the risk of complications after transplant. Next slide. It's very important to note that transplantation is not a cure for kidney disease, but it's a treatment. Next. And why do I say that? Because patients are going to require lifelong medications in order to prevent the body from rejecting the kidneys. Next. So why is transplant better than dialysis? I showed you that if you get a transplant, you're going to live longer and better than transplant. There are a couple of other things that's important that transplant may bring up that dialysis are kind of limiting. One of them is independence and ability to work. The third one is fewer dietary and travel restrictions. So if you're a candidate for transplant, these are things that you're going to be looking forward when you get your transplant compared to when you're on dialysis. Next slide. And unfortunately, not every patient is a good candidate for transplantation. So you have to be healthy and tolerate a major surgery in order to go transplant. You cannot have any life-threatening health problems, and you can also not have any active infection, cancer, or drug abuse. In addition to that, most of our patients are going to require a very good support system, family, friends, that may help them through the process, because it's not easy to get a surgery and then try to get comfortable with all the medications they're going to be required looking forward. Next slide. And one of the very important crucial points that I want to phrase is that there's no age limit in order to get a transplant. However, if you're extremely limited because of other health issues, that may be a major consequence and may prevent you from getting a transplant. But we have transplants up to 80-year-old patients that were healthy to start with. Next slide. So when we think about transplantation, there are two major ways for us to get a kidney. Either you get a kidney from a deceased donor, and that's about 2/3 of our patients. You have to wait on a list until about 4 to 6 years in the New England area, so you cannot get a kidney immediately. About 1/3 of patients get a living donor. Next. And the big advantage of a living donor is that you can plan the surgery, and in a lot of times you can avoid having to go through dialysis. So you can get your transplant much earlier than with a deceased donor. Many times a family or a friend may donate a kidney, and also there's a lower risk of rejection, and also these kidneys tend to last longer than deceased donor kidneys. Next slide. So if you think about the deceased donor, unfortunately, if you don't have a living donor, you're going to have to wait on the list. The big problem that we have is that there are not enough kidneys for the number of patients that we have on the list. There's about more than 100,000 patients in the US that are waiting for a kidney transplant, and we only have 12,000 kidneys a year. So how do we do to allocate all these kidneys to the patients that we have on the list? Next slide. So there's a national system organized by UNOS that's computerized, and that gives you a point for every year that you're on the list. And also it counts if you have started dialysis already, so it starts counting retrograde. Next slide. And you get some extra points if you're sensitized or have a difficult to find a matched donor. Next slide. There are certain cases where you may get a kidney that is a complete match or near perfect match. And this is almost a lottery. It's very hard to get that. And you just get in a very small percentage of cases. Next slide. So unfortunately, for most patients, what it means is that you're going to be on the waiting list between 4 and 6 years once you get listed. Next slide. There are not one type of kidney from the deceased donor list, but we try to classify these kidneys according to a score, which we call the KDPI score. So there are 10 different donor characteristics, which include age, that classify the kidneys from 0 to 100. Usually age is what drives a lot of the score. So if you're very young, your score for this deceased donor is going to be very, very close to 0. And the older you are, the higher the score. And you draw a line usually at 85, and we consider, kidneys that are above 85 kidneys that we're going to preferentially give to older patients because they tend not to last as long as a very young kidney, but it's enough for most patients to live a good quality life. Next slide. So a very important point is that we want to maximize your chance of getting a kidney and getting you off dialysis. So accepting higher KDPI kidneys above 85% can give you an advantage of kind of putting you on the top of the list. Next slide. Not only that, but also if you consider accepting what we call increased risk kidneys, that may also bring you to the top of the list. So what is increased risk kidneys? Next, increased risk kidneys are kidneys that come from donors that have a high risk behaviors, such as IV drug use, multiple sexual partners, or time in prison. And why is this important? Next. So there's a risk of transmitting infection in case when we test this kidney, we are unable to detect. But the risk of infection with our current testing is very low. It's below 1 in 1,000. Next slide. The reason why we need to consider these kidneys is that they usually come from very young donors. So they're very good quality kidneys. And about in New England, for example, 30% of the kidneys come from patients who are at increased risk, unfortunately, because of opioid overdose and other drugs. So by accepting increased risk kidneys, and usually we're very careful in terms of the testing that goes along, you're able to get a very good quality kidney at a shorter period of time. Next slide. So once candidates get evaluated, they have to go through a process that involves a multidisciplinary team and multiple general medical screening tests in order to determine the candidacy. Next. And then once the kidney determines if you're going to be benefiting from transplant, you get listed for this transplant list. Next. And we at Mass General, we have a special evaluation that occurs a little bit later. So we do this initial assessment and we quickly get you to the list because we want you to accumulate time. And once you start getting ready and on the top of the list, so when your kidney may get an offer for about 12 months away, this is when we bring you in for what we call the readiness evaluation. So we determine if you're healthy enough to actually undergo a kidney transplant. Next slide. And we undergo further testings that are going to be crucial to get you prepared and optimized for this surgery. So we don't ask to do all these tests ahead of time, just because a lot of times after 2 years, we have to repeat those testings. And the most important aspect, as I showed you, is to try to get you on the list so that we can accumulate time. Next. So what I tried to show you here is that it's really important that you think about your treatment options very early, and your kidney doctor is going to be the main person who is able to discuss with you some of these indications, as well as your transplant physician. Transplant is associated with a much longer and better quality of life than dialysis for those that are candidates for transplant. And living donation is the best treatment option just because you can try to plan ahead and try to time it so you can get the kidney at the perfect timing. And then last of all, to decrease your wait time or to get you ahead on the list, it's really important if you're in slightly older age, above 60, that you consider a high KDPI kidney and also an increased risk kidney donor, because that can give you a good quality kidney and can also move you ahead of some other patients that have not accepted those organs. Next. And with that, I thank you, and I'll be happy to answer questions. Thank you.
Great. Thank you very much, Dr. Riella. And I know there's some questions already coming into the chat, and I encourage you to add any you might have, and we will take them up in the Q&A. I would next like to introduce Dr. Nahel Elias, who will discuss the ways in which COVID-19 has affected transplants. Dr. Elias is the surgical director for the Mass General Kidney Transplant Program. He is an abdominal transplant surgeon dedicated to kidney, liver, and pancreas recipients care. Let me just turn this right over to you, Dr. Elias.
Thank you, Barbara, and thank you to the Betsy Lehman Center and iPro for the opportunity to talk to everyone here, and thank you all for attending. Next. I do not have any financial relationships to disclose in relation to this talk. Next. So as we all know, COVID epidemic has hit us in the past few months, and this is caused by the SARS-CoV-2 virus. Started as an outbreak late 2019 in Wuhan, China, and early this year, human-to-human transmission was identified, which primarily happens with respiratory droplets that all of us are putting out in the air as we speak, as we cough, as we sneeze, on and on. The lungs are the organs most affected by COVID-19, and patients would have respiratory failure, but also other organs are affected, like the central nervous system with the brainstem, the gastrointestinal tract, the cardiovascular system with patients having thrombosis and other problems. But about 25% of patients who had COVID had some degree of kidney injury as well. So the kidneys are affected. In addition to that, the COVID does cause more disease and more severe disease in high-risk population with pre-existing condition, and having kidney disease as well as having causes of kidney disease like high blood pressure and diabetes are all risk factors. And also having a transplant because of the immunosuppression is considered a risk factor. Next. Excuse me. And transplant affected us, transplant got affected by COVID significantly. You see here on the left top is the number of transplants performed in the US every week. And that number is roughly about 800 per week. And during the COVID surge up in March and April, that went down to about 400 per week. And primarily the drop was related to live donor transplants, as you see in the bottom left. And on the right plane here, you see the Northeast region. So that's New England, New York, and New Jersey. And you see how the numbers have gone down significantly more than in the US overall. But also the live donor transplant went down to 0 for a few weeks. And the deceased donor transplants went down significantly. Next. And what that translated into is when we look at the cumulative number of transplants performed in 2020, as of March 1, we were about 1,000 transplants ahead of 2019. 2019 is shown here in blue and 2020 in green. Unfortunately, with the epidemic, the numbers went down significantly, and right now we're about 1,000 transplants or so behind as of June 1 compared to June 1, 2019. Next. And on the right, you see the situation in New England, New York, and New Jersey. And you see the numbers that really the difference in the country across the board is primarily the difference that happened in New England, New York, and New Jersey. The Northeast got affected more than anybody else because of the surge that we had in the past few months. Next. And as you see here, for live donor transplant, the difference was most significant. Next. And you see on the right, as I said, there were no live donor transplants, so the green line is flat for a couple months or so, and now it's starting to increase slowly. Next. The deceased donor transplants got affected, but not as much. And you see here, the entire country has caught up to 2019 numbers. So although we were ahead, we decreased, and now we're catching up as of June 1. Next. And on the Northeast, that number we're still behind and we haven't caught up yet. Next. An important factor that got affected is us seeing patients to get them on the wait list and get them evaluated. And this is where across the country, about 1,200 to 1,500 patients per week are added to the wait list. That number has decreased to about 800 to 900 per week, as you see, as of the end of May. The other, that's shown in the green line, but also in blue bars, we see the number of patients that were made inactive because either they decided they do not want a transplant during the COVID epidemic, or their center decided they would not do transplant during the COVID pandemic. Next. In the Northeast, the numbers are also most significant, as We usually add to the list about 200 patients per year, per week, sorry. And that dropped to about 100. And again, the number of patients that were made inactive in the blue bars shown here. Next. And why did transplant stop? Well, every time we talk about a transplant, as you heard from Dr. Riella earlier, we compare the risk of the transplant to the benefit of the transplant. And in most patients, there is significant benefit of survival and improved quality of life that it justifies the standard transplant risk that we evaluate and say that this patient should get a transplant. Next. What COVID did is that it added to the risk, but it also added to the benefit by taking the patient out of the dialysis centers. So if a patient gets a transplant and the transplant functions well, the patient no longer needs to go to dialysis center where there is some risk of getting infected with COVID. Now, the trouble with COVID risk to the transplant is also significant. Next. And that is a risk that really was the reason behind CMS, the CDC, and the United States Surgeon General recommending cessation of elective surgery, primarily to conserve critical resources. We're talking ventilator, we're talking PPEs, we're talking operating rooms, ICU rooms, and beds in the hospital. But also importantly was to limit exposures of patients and staff to the virus with limiting the number of transplants and the number of elective surgery overall. And when we talk about transplant, the risk that we're concerned about related to the recipient, because when we transplant a kidney or any other organ, we're adding immunosuppression to the patient. So we're increasing their risk of getting an infection. And what does the infection do to them if they have immunosuppression compared if they didn't? The other concern we had was donor-derived infections. Would we be transplanting a kidney and giving the patient COVID if the donor had COVID? We still do not know the answer to that, and has not had any cases across the world, for that matter, that we know that patients got COVID because they got the organ transplant from somebody who had COVID. But we are not willing to take an organ from somebody who has COVID. So it's very important that we're being careful from that perspective. We're also concerned about the patient coming into the hospital and being in the hospital. Would they get an infection because somebody else in the hospital has COVID? So this is where we talk about nosocomial or hospital-acquired infections. And so far, there have been some data that, from China, from Italy, where they showed that there were hospital staff and providers who got infected because of patients. It is not known that patient-to-patient transmission has happened, but in theory, it could happen. And in addition to the concern about that in recipients, we're very concerned about that in a live donor, because remember, that's a person who does not need the operation, who's doing a great act by donating a kidney and coming in to have an operation they don't need to help somebody else they care about. And this is where the last thing we want to do is to hurt them with getting them infected or anything like that. So this is where living donation really almost completely stopped in places where the pandemic was surging, like we had here in New England, for example. Now, obviously, deceased donors were not concerned about them having the virus because they're no longer alive. But on the other hand, we're not going to use their organs if they have the virus. And these donors are taking significant resources when they're in the hospital, ICU beds, OR, PPEs, and that's an important piece to talk about with the resource preservation that we had to do across the board. This is why testing was very important, and as testing has improved significantly over the past few weeks to couple months, we now are able to test all recipients before we perform the procedure, and we do the rapid testing, which facilitate things. We also test them afterward if there are any concerns. We are testing all live donors before they donate. Obviously, deceased donors we're very careful about, and we are testing all deceased donors, and there are protocols across the country for this. Isolation practices has been recommended off and on, but nowadays we're, as the surge has eased in New England and the Northeast, we're doing less of the isolation, but again, making recommendation to patients before they're having their procedure. Next. So what are the considerations for patient after transplant? Remember, all along, we've recommended to our patients to be careful, to be aware of their surroundings, really to be using hand sanitizer, being careful around sick people. And now these recommendations that we used to give to transplant patients, we're all getting, everybody's have to follow these recommendations. So the recommendation to transplant patients is a notch above that, where we have to be more vigilant about their risk contracting the virus, because their risk when they get the virus is significant. And although we heard, for example, last week that some steroids may help the patient when they get COVID, and a lot of transplant patients are on steroids, and that may help them, that they may have less of a disease severity. On the other hand, the data we have from the early pandemic places like China and Italy, and in the US, in New York and Washington State, showed that patients who got a kidney transplant and then got COVID had a mortality risk of 10 to 25%. That's 10 to maybe 20 times the risk of the general population, if you think of it. And that's primarily because they had the pre-existing conditions that we're worried about. And most of these were kidney recipients, as I mentioned. And again, the data is very early, but we're continuing across the country to look into registries and looking at patients and how they did and how were we able to manage them. But we're very concerned about the patients, so we're very careful about that. Next. For that reason, we're having to deal with this new reality in healthcare that really is reducing the risk, which is not anything new. We've always dealt with reducing the risk when we talk about healthcare. On the other hand, we have to be careful about it in the days of COVID and in these days. We're careful about that in operating room when we're operating on patients, identifying their risk and their status, because everything we do in the operating room, putting the patient to sleep and operating on them, really causes these generation of the aerosols, the material that if they had the virus, that would be transmitted and that would be going to other people in the operating room. So we're concerned about the staff. For that reason, we're rapidly testing everybody. And patients who are undergoing emergency surgery, we obviously cannot test them, but lucky for us, transplant is not exactly an emergency. We have some time, and we're currently testing all patients who are undergoing transplant. We're taking all the precautions by protecting the staff and everybody with our practices. We're also careful in the hospital. Every patient who comes in gets tested, and we are very careful about the staff as well. So every person who comes into the hospital, who works in the hospital, has to declare that they do not have any symptoms and they're doing well. We're careful in the clinics as well, and you're gonna hear a little more from Michelle about how we're screening staff and patients every day and about virtual care. Next. So this is where every patient, before they come in, we have an e-check on the patient portal, and we make sure that they're doing well. We screen everybody who's entering the facility, as I mentioned, all patients and staff. We all have to wear masks all the time when we're in hospital areas. We are very careful about our social distancing in our clinics, in our waiting rooms. So we made sure that patients are not sitting next to each other. The cleaning protocols have all been revamped and are more frequent. And we separate where patients are being taken care of if they have COVID compared to the rest of the patient population. I'll stop here, and Michelle will talk a little further about this. Thank you.
Perfect. Thank you so much, Dr. Elias. It's interesting to hear how practice has had to evolve and will continue to evolve during the pandemic. So next up is Michelle Scala, a registered nurse and pre-transplant coordinator. Michelle works with the MGH abdominal transplant team. She specializes in the care and coordination of patients needing kidney and pancreas transplants. She also coordinates with other MGH transplant programs to assist with patients who are listed to receive 2 organs. So Michelle, let me turn this over to you.
Thank you, Barbara. Hello and good evening. My name is Michelle Scala, as Barbara introduced, and I am a pre-transplant coordinator and a nurse working with the abdominal transplant team at Mass General. I'm responsible for seeing patients from referral through evaluation and waitlisting and right through to their transplant. And I work alongside a team of coordinators, and we divide the patients that are referred to us by region, where they live regionally. So I cover north of Boston and Maine. So if you live in those areas, you'll either meet me someday, and I hope to meet you. My topic this evening is what's next? What clinic visits to MGH will look like now with the COVID-19 pandemic. Next slide. The MGH transplant team would like you to know that we have a long-standing commitment to the health and safety of our patients. During the COVID-19 global pandemic, we quickly established new protocols to provide transplant care. Even through the height of the pandemic, we were able to evaluate and list new patients as well as provide follow-up care for patients after transplant. In the new reality, you will notice differences in the way care is provided. MGH is offering safe care commitments to our patients, and we've highlighted our efforts here in this slide. And Dr. Elias referenced many of the changes we've made. So in-clinic visits or in-person or traditional face-to-face visits are now done with enhanced safety protocols. This includes an alternative check-in process by which patients are called and screened for COVID prior to the scheduled appointment. Patients are then calling the clinic when they arrive to their appointment, and the front desk staff answers these calls. And the patients are invited up to the clinic, and they are escorted directly to a private room. They're greeted by an MGH employee who will provide mask and hand sanitizer and take their temperatures and perform the screening questions once again. So we are limiting the total number of patients that are allowed in clinic per day as an added safety measure, and enhancing the cleaning procedures in the clinic as well. Next slide. Many of you may have heard of virtual visits. Virtual visits allow patients to see a provider from home over a computer, a tablet, or phone. And the MGH patient portal called Patient Gateway, in conjunction with a super secure Zoom conferencing platform, allows our patients to be evaluated remotely. This is important as we work to place appropriate candidates on the waitlist as soon as possible. Our schedulers are now experts at assisting our patients in setting up the technology needed to conduct these visits. We have received feedback from many patients that they're thrilled to have this option. It's convenient, it saves costs associated with travel and parking in Boston, and of course it keeps them safe during the pandemic. Virtual visits are now part of our practice, and they're here to stay. And it also allows our patients to have a support person with them at their appointments, which is another added benefit. Next slide. This slide gives an overview of the applications necessary to be able to be scheduled for a virtual visit with MGH. Again, our schedulers would be able to help guide you through the process. You can enroll in the Partners Healthcare Patient Gateway online to get the process started. And just touching a bit on the format of our virtual appointments, they're very much like our in-clinic visits. The day consists of multiple appointments from the different disciplines that make up the transplant team. And during those appointments, you can expect to meet one of the medical professionals, such as a transplant nephrologist or nurse practitioner who would go over your medical history with you. You'd meet a nurse to go over education and planning, a nutritionist, a social worker, and you would receive a call from a finance coordinator who would review your insurance and also discuss costs associated with the medications you could expect to be on after transplant. And these appointments are similar for our new patients as well as our patients who are getting ready for transplant. Fun fact, we've listed 45 patients since the start of the pandemic. We are proud to say that we keep the momentum of evaluating our patients moving through this tough period. Virtual appointments are here to stay, and each week we're growing and defining how best we can keep this momentum going. A few things we've initiated during this time period as well is acquiring the genetic information we need to list a patient by sending out kits in the mail that are sent by the tissue typing lab. It's called a swab kit, and the patients simply swab the inside of their mouth and package up the sample and send it back to MGH. And we need that information for listing. We've also added recipient education videos on YouTube, and our schedules have been forwarding these links to our patients so they can watch them at their leisure. Virtual appointments were emerging prior to COVID, but by expediting the process, we've learned so much in a very short period of time about how we can reach patients at a distance and make this process of evaluation more convenient, all the while keeping them safe. You can go to the next slide. We sincerely thank you for the opportunity to present to you this evening. Any questions or comments related to our topics tonight are always welcome. Sorry, I forgot to advance to the last, the last slide, but there's the information. Back to our hosts.
Great, thank you very much, Michelle. So before I introduce our final speaker, I just wanted to remind everyone to type any questions you have into the chat that you have so far, and we'll have them ready to go for the Q&A, which will be coming up next. So I am delighted to introduce our final speaker, Kim Pratt, who's going to share her personal experience with a kidney transplant. And Kim received her transplant 1 year ago and is a patient advisor for ESRD Network 1. So, welcome, Kim.
Hi, greetings to everyone. I'm really happy to be part of this Zoom tonight. Yes, I am part of the ESRD network, and I'm one of patient advisory, and I'm really thrilled to be a subject matter expert on transplant now. My name is Kim Pratt, obviously, and I am 52 years old and mother of 3 residing in Rhode Island. And hope is our state motto, and hope has carried me through the phases of my kidney disease. In this slide here, you will see a timeline progression of my diagnosis with kidney disease in 2014, all the way to receiving my kidney transplant 1 year ago. Tomorrow will be my anniversary, and I can't believe it. It feels like it flew by. This path was full of obstacles and goals to reach. I've never been thin, and in order to qualify for my transplant, I was encouraged to seek gastric bypass surgery to lower my BMI for the transplant list. I managed to lose 190 pounds, and that surgery took place November 2015. And then I also required to have the skin and hernia surgery in 2017, which helped me to lose 190 pounds. And there I was able to be placed on the waiting list, and I was thrilled about that. I was driven to improve the quality of my life, so it is quite understandable that I would make the very best choices to preserve my transplant each and every day. During the COVID pandemic, I have my 18-year-old daughter shop for our needs and follow guidelines offered by our governor and health officials. I take walks every day outside, away from crowds, for my physical health. I am honored to share my experience and support dialysis and transplant patients through social media. For instance, there's a site called Dialysis Discussion Uncensored, and every single day I learn of things I didn't experience with other patients, and I'm able to input my experiences and help people along and be supportive. It's a wonderful place that I also can advertise things from the ESRD network or things that are going on that I can share, and people are very appreciative to that. I also, with my old dialysis clinic, I share information as a PAC member, as well as through the transplant clinic support group, where social workers offer my number to potential transplant recipients. During COVID, we're not having the support group, so there's the social workers will have me speak to any potential transplant recipients and give any advice and experiences that I have, I've gone through. Been through a lot of different things over the 5 years of being a dialysis patient. I've seen a lot. Luckily, the Rhode Island Hospital Transplant Clinic staff are available to answer any questions any time of the day regarding my concerns. I'm extremely lucky to have those people in my corner to advise me. Hope is what I want to embody during these uncertain times. I understand that transplants are being on hold, and I'm very fortunate that I received my kidney. Tomorrow will be 1 year ago, and I didn't have to experience that. But as a patient that had to roll with many different things thrown at me as a dialysis patient, I just kept having hope and just move forward. And I'd be happy to help any patients that have any questions for me.
Great, thank you so much, Kim. The perspective you bring as a patient is just incredibly important, and we really appreciate your generosity and willingness to share your story. So thank you again.
Thank you.
So we're going to transition now to our question and answer session. And before we do that, we're going to run just a quick poll, which we could launch that poll. Okay, so since the COVID-19 outbreak started, when I think about my health, sort of what's my level of concern, and most of you have more concerns than you did before, and over 40% of you have a lot more concerns than usual, which is completely understandable. The second question, so what do you do when you have questions about how COVID-19 affects your kidney health? And I'm sure, especially our physician and nurse panelists will be happy to see that most of you do talk to a health professional, and some of you also try to find answers on the internet, which is, of course, the 21st century way of doing things, and many of you probably do both of these things. So great. So thanks so much for answering. And at this point, I would now like to introduce Megan Paris. Megan is a quality improvement coordinator at iPro, where she develops quality improvement activities and works to provide educational opportunities for kidney patients and for staff. She also has over 12 years of clinical experience as an LPN. So Megan, I'm going to turn this over to you so that you can lead us in the Q&A session.
I was going to do that. I started talking and I was muted. Thank you for that, Barbara, and thank you for everyone for being here. Just a couple housekeeping things. So we have a lot of questions so far. As a reminder, if you see on your screen a chat icon, you can click that and it opens up a box. You can type and send your message in that box. Please let us know if your questions are for a specific presenter, and we will address as many questions as we can. You will also see that you have an option to raise your hand. As you see on your screen, there are participants icon you can click. Once you have clicked that hand, a box of names will pop up, and at the bottom of the box, you will see raise hand. We will call on people with raised hands as time permits. If you are currently muted, you can then unmute yourself if you are called upon so that you can share your questions with us. This meeting is being recorded and all chats are retained. Audience members' audio is not displayed in our recording, but your spoken comments are. If you have concerns about recording, please send us a chat to the Betsy Lehman Center. Because of this, please do not share any sensitive information that you do not want to have recorded, and kindly refrain from naming individual clinicians and staff when speaking about your care. So with that, we're going to move on to our questions. And I have, let's see, first up, let me move my screen. Okay, so for Dr. Riella, for a living donor transplant, how much greater risk is the risk if the donor is in California and I have a transplant at Massachusetts General?
Great. That's a great question. So for many patients, they may have family members or friends that are not in the same area where the patient is right now. Fortunately, the way the system works, we can organize to have a living donation even from outside a state. So there are ways to coordinate this and either have the patient, donate MS General or in California, and even probably Dr. Elias want to kind of phrase from that a little bit as a surgeon, because he has a lot of experience with some of these more distant donors.
Yeah, absolutely. We've done these, and we were actually one of the first centers in the country where we had a donor in San Diego, and the kidney was shipped to us, and we transplanted it here at Mass General. The risk is very minimal. These kidneys are very healthy when we talk about a live donor, and we're doing this all the time with deceased donor kidneys. They get shipped to us from everywhere, and we put them in. There is a slight risk of the kidney not functioning right away when it has been taken out of the body and has sat on ice for a significant amount of time. But at the end, the kidney recovers almost always, and the kidney function and the longevity of the kidney is not affected significantly by that. So I would encourage that, and we prefer to do that if the donor is not able to come here and they want to donate where they live and recover with their family members and support. It's absolutely a great idea, and we will support and facilitate that.
Thank you. Dr. Riella, this is also for you. I live in Maine. Can I get on the Mass General list?
Yeah, and you're going to be lucky at having Michelle as your coordinator. So this in theory you can be listed in multiple hospitals in the country, and we're lucky to have patients that come from Maine, New York, Rhode Island, New Hampshire, and other states in the country, and Michelle will be happy to guide you through the process in order to get that happen. I think the big, if we have one positive thing about the coronavirus and COVID, has been the telemedicine and the capability for us to starting some of these visits from a distance and accelerating the process. And it's quite convenient for the patient. Of course, we have to see the patients in person as well as at some point, but at least, for some of the healthy potential kidney candidates, it is great to be able to see them ahead of time, get them on the list if possible, without actually requiring them to come to the hospital if possible.
Thank you. This is for both Dr. Riella and Dr. Elias. A little bit more explanation about the high discard rates for kidneys, the KDPI. There was some questions about that, a little bit more explanation. I know you both had talked about it, I didn't know.
Well, I can start just talking again about what is the KDPI. So this is just a score that is used to tell us a little bit about the kidney characteristics of the donor, okay? So if you get a kidney from a deceased donor that's 20 years old versus someone that's 60 years old and had hypertension, we know that the kidney quality is gonna be slightly different. We have made some changes in the way these kidneys are allocated or distributed. So if you're younger, there is a longevity match where you're gonna get kidneys from younger donors. If you're older, a lot of times getting a kidney from an older donor, someone that's in his 60s or 50 with hypertension, even though they may have this high KDPI, so a higher score, and the quality of kidney is not as good as a young kidney, it's enough and much better than staying on dialysis. And therefore we assess on an individual basis, and we encourage patients that are older, above 60 years old, to consider this kidneys. And of course, again, considering the kidney doesn't mean that you're gonna receive a kidney that's not good for you. There's a second layer where the physicians, the surgeons are gonna go over the kidney and make sure that this kidney is the best quality possible. And even in cases where we get this kidney that's higher KDPI, we do a biopsy of the kidney to see how it looks. So not only we look at the numbers, the blood test of the donor, but we're also looking at the quality of the kidney in order to determine that. There's still a lot of kidneys that we don't accept, those are discarded. However, there's a good portion of these kidneys that are accepted, and the outcomes are quite good.
Perfect. Thank you.
Yeah, I agree with what Leo was saying, and I also want to emphasize, the KDPI is calculated based on the donor characteristics before we look at the kidney, before we take it out of the donor. So because it drives the allocation into who should get the kidney, we have all the KDPI is based on information of the health of the donor, their age, their comorbidities, their size, and their creatinine. Once the kidney comes out, as Leo mentioned, we do the biopsy, we do additional assessment of the kidney to make sure that this is a good kidney for the patient it's being offered for.
Perfect, thank you. Dr. Elias, this is for you. Is there any insight into the risk of COVID-19 based on having been in this 10% category of having activated post-transplant CMV? Is there any increased risk?
I'm not aware of any correlation between the risk of CMV and the risk of COVID-19. Obviously, your team who's caring for you would know best about your infectious risk. All patients are at risk, and the CMV is a very common virus. About half the population, half of us here have seen it in our lifetime, and it doesn't cause trouble in most patients, but after transplant, it does cause trouble. And this is where if the donor had it, it could be transmitted with the kidney. And that's how CMV, we know about it, and what we do is we prophylax the patients once they get the transplant to avoid problems, but we keep watching for it afterward. And patients who get it, it's really very common as opposed to COVID. I mean, it's a lot more common than COVID. As I said, 50% of the population has it. It just doesn't cause a significant disease except with immunosuppression. Obviously, your team should know better about your immunosuppression and your status, and would be better to advise you on that, but I do not believe there's any cross-reactivity between having CMV and having COVID.
Thank you, and that kind of leads us into this next question, Dr. Elias. It says that I read of a COVID patient in China, a kidney transplant recipient. They eased up on the immunosuppression and did other things to protect the kidney health. Is it standard practice? Have you had much experience with a COVID-infected kidney transplant recipient in Boston?
Yeah, we roughly had about 50 patients at MGH who had a transplant and presented with COVID. You are correct. We do adjust the immunosuppression to decrease their risk of having problems from COVID. And depending on how sick they are, we've had many patients who had COVID and they had a kidney or a liver transplant or other transplants, and they were at home and they did not have any significant symptoms and they did well. We do adjust the immunosuppression based on how sick they are. Patients who are extremely sick, who are in the ICU on ventilators and in poor shape, we do decrease their immunosuppression tremendously because we want their immune system to help fight the virus. So yes, we do adjust that. That's standard and that's routine for almost anyone. The steroid part is what we keep on, and as I mentioned earlier, there is some benefit to having steroids on in these patients, and we do support their kidney and the rest of their organs depending on what they need for support.
Thank you. Michelle, this is for you. Okay. This person was asking, will they be getting monthly blood kits?
So we did slow down with sending out the blood kits over the pandemic, but our patients that will be receiving monthly blood kits are patients that are at the top of the list or that we've identified as moving into the readiness process. You know, if you have a question, you can always call the center. But if you're not getting them right now, we wouldn't necessarily be getting them until I called you or one of us called you to let you know that you need them.
Thank you. That actually kind of leads me into my next question. It says, I understood donors who were not a match would go to another recipient who matches. Then is that intended recipient moved up the list? Because this would kind of be open to anybody.
So if there is a donor who does not match the patient, most of the time we participate in swaps. So that donor could donate to someone who has a donor who does not match them. And in return, that donor will donate to the patient. So for example, if I need a kidney and my brother want to donate to me and he's not a match, my brother will donate to somebody whose brother will donate to me. So these swaps are what we do routinely. Going up the list on the deceased donor has been proposed but has not been approved yet. There's a lot of talk about it across the country. If you could get a living donor kidney in a swap, in my mind, that's better, and we know when, and we plan it and we schedule it, which is better than getting a deceased donor kidney, I would recommend. But again, for some patients who are difficult to match and there is no other options, that could be something that we can, hopefully, if it passes the regulations, we would be able to help them that way.
Perfect, thank you. Kim, this one's for you.
Oh, interesting.
A great question for you. It says, I have been on dialysis for 3.5 years, 3.5 years, and I have no side effects, and I am currently working. Will my quality of life change after transplant? What's your perspective on that?
Yeah, I do feel it will change for the better. Dialysis, I just rolled with it. I had to do it, but I'll tell you, I feel a whole lot better having a transplant. When I see pictures of myself as a dialysis patient and I was exercising and I felt I looked healthy, I felt good, because in that time, that's how I felt. But now I could see it in my complexion. I feel a whole lot different, more than I thought I would. And you're not chained to a dialysis treatments. You can travel more. The diet is different. You know, you can eat bananas and dried fruit now, and it's different. I just feel that it is an improvement in your life. I would definitely pursue getting a transplant. I feel that, from what I understand, the statistics, you tend to live longer with the transplant. And just because everything's going fine, I still would really seriously look into getting a transplant.
Thank you, Kim. And with that, Barbara, I think we're kind of all set here if you want to turn it back to you. Thank you.
Great. All right. Well, thank you. So I want to thank you all again for joining us, and particularly to IPRO and the Mass General team and all of our speakers. To close, we wanted to do two things. The first is to let you know that you can email us with feedback, questions, comments, and Michelle from the Betsy Lehman Center is sending you her email right now via the chat. So you can send a message to her if you want to share anything with us. This is actually the second kidney-related town hall that we've done during COVID, and we're open to doing more. And so, and especially want to hear from you about topics that we could be covering. So the second thing I want to do is to launch one final poll, and we're going to leave this open for a minute or two so that you can respond. And it's kind of just a few questions. Scroll down to make sure you answer all of the questions. This actually helps us with our planning as we plan future sessions like these. So, again, just thank you for spending this time with us. Be safe and healthy, and have a great rest of your evening.